Hi guys, Benji at Benji Physio. Today we're going to look at problems with the acromio clavicular joint. The acromio clavicular joint is this joint at the top of the shoulder. I like to say that it is a joint at the roof of the shoulder complex. As its name maybe tells you, it's the joint between the clavicle, which is a collarbone, and the scapula, which is in fact the shoulder blade. And on this model, which is a right shoulder, you will see that your scapula is in fact, when you look from the front, quite flat, but when you look from the back, you can see there is this kind of protuberance, which we call the spine of the scapula. And when you just come up and follow the spine of the scapula, it will just come to that ridge called the acromio, okay, which is part of the bone of the scapula. And this is this acromio that is going to joint and form the acromio clavicular joint with the collarbone. So there are two types of problem really we can have with this acromio clavicular joint. We call that as well ACJ. The first problem, it's going to be injuries due to a trauma. It's when you fall on it and you hurt it. We will see that generally in rugby players, in mountain bikers and skiers, and we fall. And the other one as well is due to a car accident when the patients have got the belt over the shoulder and they lean forward, and that will injure the acromio clavicular joint. There are a couple of classifications that can be used to categorize the different type of strain or injury you can do the ACJ, but the one I like the most is the Rockwood one because it's just a bit more precise. In its classification, Rockwood subdivides the different lesion in 6 parts, okay? But I'm not going to bore you with all of that because it's very boring if you are not into it. But what you want to really see, the first thing you are going to see, as you can see in your acromioclavicular joint, is a bit more complex than it looks, because obviously you've got the acromioclavicular ligament here, and you've got on top of that 2 beautiful structures there that joint that little bit, called the coronoid protuberance, which is just, you can touch it just at the front of the shoulder there, and those coronoid ligament there attach your clavicle properly, like that it doesn't float too much. Okay. So in Rockwood, in its classifications, the type 1 is just going to be a bit of a strain here. So you've got just a small tear of the ligament of the joint without ligament of almost overstretch in some ways, okay, which is going to give you a bit of pain, but normally it doesn't give you a lot of limitation. In the second part is going to be the joint by itself there is broken, okay, there is a tear of the ligament completely and a small separation, but no major movement of the shoulder, of the collarbone, so the collarbone doesn't come up, okay. It's number 3, type 3, is going to be this time a tear, complete tear of that joint, complete tear of the ligament, and the shoulder start lifting completely. And the 3 other is different type of more complication. You've got sometimes it just lift even more, sometimes the collarbone drift posteriorly backward, and sometimes it just can't come forward. There are different classification. But it's clear, what is very interesting is for the type 1, which is just a little bit of a small tear, it's going to be quite pain after the trauma, but you would almost expect the athlete to go back to training almost straight away because there is no major disturbance in the joint. It's just painful. You pad it quite well, you put some taping, you do your classical physio technique around that joint, and you get the player back to training straight away, playing straight away, and continue your rehab at the same time, just to make sure that over the next few days, few weeks, the pain doesn't get worse. With the number 2, classification number 2, when there is a bit more tearing, that's going to be a bit more painful. The athlete might find that it's a bit too difficult to play yet at that stage, and you need to just be a bit more conservative, and that means a bit more time of the pitch. Number 3, definitely when you start having a bit of gapping happening, this is when you start thinking, okay, we need to be a bit more careful with that. Once again, if it's not too pain, you just pad it well, and maybe the player can go a bit quickly, but you're a bit more worried. And when there's a full tear completely and the clavicle it just comes up completely, that's going to take a lot longer. Unfortunately, we don't see a lot of surgeons operating on that joint. I know a couple of them only, but that I would always advise to do that. As soon as your collarbone just lift off completely, and it's like a piano touch, when you poke on it, it just goes up and down, I would advise quite quickly to get that repaired, because it means quite a bit of trauma, and you don't want to be left with a collarbone that moves up and down all the time. The other type of lesion we are going to see on the acromio clavicular joint is caused by degenerative inflammation, so changing in the joint due to repetition of stress in that joint. So that's the opposite of trauma. Trauma is one big injury on it, and then the degenerative is when you just cause trauma after trauma. That could be caused due to a repetitive strain injury, so let's say a javelin thrower, or an activity, a painter sometimes can start develop over the years some problem with that joint. But you will see that as well a lot in patients with poor posture. So this is going to be the typical patients with a bit of this kind of position. Instead of being straight, they tend to come a bit more too much forward. The shoulder, the head of the humerus tends to come too much forward, and because you are doing that, you are increasing the stress on the acromioclavicular joint. So instead of using properly all your muscle of your rotator cuff, which are the tendon around the ball of the shoulder, allowing you to move your arm, when your shoulder is protracted that way, you tend to have a weakness of the rotator cuff, and you tend to start putting too much stress on your acromioclavicular joint, and it becomes painful. So at the opposite of trauma, which normally the rehabilitation is very quick, and as soon as the patient is able to do the activity they want to do without too much pain, we're happy. The acromioclavicular joint degeneration is a bit trickier, because as you've understood now, just trying to do a bit of massage and taping on that joint is not enough. We need to just change completely the biomechanic of the shoulder, which means that we need to try to teach patients to have a better posture, which means really trying to just be straighter, starting to strengthen the muscle at the back of the shoulder to retract more your shoulder, loosen off the pec muscle, which is a big muscle at the front of the shoulder that just will come and attach there and pulls your head of the humerus forward. So normally that, if we work on that, and that can take a few weeks and a few months. At the clinic, I won't see patients every week for those kind of problems. Once we've got the acute pain, the nasty pain away, what we tend to do is just a lot of exercises either at home or at the gym, when we work on strengthening mobility of the spine, strengthening of the rotator cuff muscles, to try to avoid the problem getting worse. And in patients who, despite of that, do not improve, we will offer to get the acromio clavicular joint injected with cortisone, and that have got good effect. Not, especially in the long term, once it's associated with good physiotherapy, some very good result with that. ACJ problem can be very often confused with another couple of conditions. The main one very often is an injury, a tear to the supraspinatus tendon. As you can see on the shoulder there, you've got this beautiful groove, and in this groove lies a supraspinatus. Supraspinatus means above the spine, okay? So this muscle lies in there, and as you can see, there's a little hole there, forming a little tunnel. And that muscle will go into that tunnel to come and attach right here, okay? Somewhere there when you can see, the screw there. So the function of the supraspinatus tendon is to do an abduction, which is this movement, okay? Because that tendon, that muscle and tendon lie just under the acromioclavicular, the two problems can be very often confused. Another problem as well is issue with the long head of the biceps. Biceps is the muscle helping you to do elbow flexion and shoulder elevation. And the biceps, as its name tells you, are two tendons, two muscles, and one of them is a long head of the bicep that just come there at the front of the shoulder, and then come and start joining a bit that little tunnel to insert to there on the glenoid space of the scapula. The second part of that bicep will come and attach on that little bony bit of the scapula again. It's called the coronoid process. And those two tendons just come down there to form the big biceps at the front of the arm. Issues with that can be confused with AC joint because they refer kind of the same place. And any other problem of the rotator tendon can cause a bit of pain at the front of the shoulder, on the side of the shoulder there, and it is possible to misdiagnose an acromio clavicular joint disease if you don't look at the other tendon before that.